So thanks everyone for sticking around for the last SAM session. And thanks to Sue and Nancy for participating. So there is a third participant, Francisco Cervantes, who is an ENT at University of Miami, who is stuck in traffic, which is typical for Miami, Fort Lauderdale. So hopefully he will be here soon. I know he's just a mile or two away. So without delaying to get things on the road, just by a show of hands, how many of you are at centers where TORS is done, at least to some degree, for oropharyngeal cancer patients? Yeah, so it's definitely something that is becoming more common, both in the community and academic practices. And really, I think that the theme of the first part of the session here was how should we view or how should we approach the adjuvant setting in patients who have received transoral robotic surgery. So with that in mind, we were going to start with a surgical approach, but since Dr. Cervantes is not here, Sue, if you don't mind sharing some thoughts about de-escalation of therapy and indications for RT. Thanks.
Okay, great. So Dr. Cervantes, when he gets here, can go over some of the anatomy and surgical considerations. If we're not able to have him, I'll go over some of the questions with you from my perspective as a non-surgeon. But the second talk that we had planned for you was to talk about the role of transoral surgery and its relationship to de-intensification. These are my disclosures as of 2017. And so the topics that I prepared to go over today, and which I really encourage you to ask questions about, because this really should be interactive, as this is a really evolving area, is quality of life and outcomes in TOS, which I'm going to define as transoral surgery, which is a little different than TORS, which is the robotic version, versus laser, which is translaser microsurgery. So we have a couple different terms, TLM, TORS, and I'm defining them as TOS, which is transoral surgery, all comers. Some people call this TOES, transoral endoscopic surgery, which I really like that term, but I'm not going to use that today. I'm going to use TOS, T-O-S. And then, so outcomes and quality of life, the current status of utilization of transoral surgery, and then the controversial issues of delivery of chemoradiation after TOES and randomized trials that are in progress now. So I don't want to spend too much time on the background of oropharyngeal cancer epidemiology or the quality of life considerations that go along with it. I think Nancy might actually touch on that a little bit in her discussion of practical issues and de-intensification. But as we all know, quality of life, well, I can tell you a few things from studies. Quality of life is generally higher in P16/HPV positive patients at baseline, and also tends to rebound at a higher rate because generally speaking in life, what you go in with is what you come out with. Quality of life tends to decline during the what's called acute and subacute period after treatments, but then will generally rebound by about a year. And this is an important principle in quality of life research, which is that in competing situations that provide equivalent or near equivalent disease outcomes, quality of life takes on a more important valence. And we know that, of course, from things like prostate cancer. So the role of surgery in oropharyngeal cancer is expanding primarily on the basis of a justification that it may improve quality of life in certain subsets. And as you can see, this very interesting paper, which was based on NCDB census data, shows that the rate of surgery for T1, T2, and that includes all end stages from N0 to N3, and there were N3 patients of a substantial number in this study, has gone from 56%, about equivalent to chemoradiation 2004, to now over 80% with a primary surgical approach in 2013. So it is certainly expanding on the rationale that T1, T2, approved by the FDA for transoral robotic surgery, is valid as a FDA-approved treatment with this machine, and also that quality of life may be improved in these patients. What are the outcomes like? There's only one randomized comparison that has directly looked at surgical approaches up front versus RT approaches up front. It's a very old study. It's from Singapore, and the 10-year long-term outcomes were recently reported. Keep in mind, this is an old study in another country with methods that are not comparable to what we're looking at now with TORS and very defined IMRT. But at least in this study, what they found with a direct comparison, again, the only one that's been done of this caliber, caliber is that for oropharyngeal and other pharyngeal and laryngeal cancers, the outcomes overall with surgery and radiation-based treatments were very similar, except oral cavity was not. And so this is really one of the important studies that people talk about when we say oral cavity is a surgical disease and contradistinction to oropharyngeal cancer. So the outcomes are pretty similar, and that has actually been somewhat confirmed in systematic reviews of TOS. Two major systematic reviews I'll point you to, which get cited all the time, are the Almeida study and the Morsud study. The Almeida study was larger and looked at almost 2,000 patients, and as you can see here, in this study, 44% of them ended up receiving chemoradiation in both cohorts. So whether they had chemo radiation up front or TORS followed by chemo radiation, was about 44% in both. And there was no essential difference in any outcomes, with the local control and survival looking very similar. And surprisingly, the PEG rate in both groups was also very similar. So that is the largest and probably highest quality, most cited systematic review that exists trying to compare the two. There's another study another systematic review of 12 studies. This used a higher standard for the evidence, trying to really whittle down to the best quality studies, and again, quite large at about 1,000 patients. And this study is interesting on the left there because it was only looking at what supposedly most people would say is the clear TOS population, T1, T2, N0. And again, T1, T2, N0, when restricting it to these low end-stage patients or zero end-stage patients, showed no real differences in local regional control or disease outcomes, although it was noted that there was significant heterogeneity among the studies, even when restricted to high quality. What about quality of life? So we know a few things about quality of life, although these studies, again, are plagued by being small, single institutional for the most part, and for the most part somewhat retrospective. But there have been a couple of studies that stand out a little bit. This was a study of prospectively collected quality of life from Kansas, and what they showed was that as the stage went up, meaning you went from T1 to T2 to T3, the quality of life at 3, 6, and 12 months was lower for the higher stage patients, but the majority of patients rebounded considerably by 12 months. A lot of people sort of use that as a sort of general guide as to what you can predict for your patients. And then this other study on the left from Davis looked at a matched pair comparison, trying to correct for the differences in selection that we know between surgery and radiation. We all know that the larger stage patients, more sick patients, tend to go to radiation, and or worse prognosis. And in this study, what they found was that most quality of life indices were very similar, except the chemoradiation patients had lower swallowing outcomes, which doesn't surprise you. So you might say, well, okay, it sounds like the chemoradiation patients have worse swallowing outcomes. That's not good. The key issue here, and the other thing that we can find out from some of these studies, is that what happens to a patient's quality of life is very dependent on what is delivered in the adjuvant phase. This is a key thing that I think a lot of maybe studies can't account for easily, because the assumption is that TOS will automatically decrease your functional and quality of life decrement. That's not necessarily true depending on what happens to you afterwards. So as you can see here from this very nice study that was just published recently, looking from MD Anderson, looking at TORS versus RT versus the top line there, which is TORS plus CRT, the quality of life issues can be more significant among the patients in the light blue there, which are the CRT, at both short-term and long-term follow-up. So if you deliver chemoradiation after TORS, you can actually turn out a little bit worse than with either RT or TORS alone, and the comparison back to CRT itself is probably similar. It also has implications in terms of cost effectiveness. So this is, I think, one of the best cost effectiveness studies, if not the best in the literature. We published this in the Red Journal. I'm very proud that this study was done so well and we were able to do that. And as you can see here, a very rigorous cost effective analysis, setting a QALY based at around 50,000 to be cost effective. And when you look at this, and this is restricted to HPV or P16 positive patients with what was called N2A or N2B be in the 7th edition staging system, what happens is that the primary drivers of whether TORS becomes cost effective or not is based again on the adjuvant therapy as well as the local regional recurrence rate. So for TOS to be cost effective for these patients in this setting, they cannot receive chemoradiation. And also the other condition is that if TORS were to be cost effective, it would have to reduce the local regional recurrence rate by over 4 to 6%, which may or may not be true. So both of these are issues that are kind of evolving, and this is the whole crux of TORS, is what happens in the adjuvant phase and how that rolls back to affect quality of life and cost effectiveness. So as you all know, it's very controversial what kind of adjuvant therapy to give in the post-TOS setting. The traditional indices are derived from both high-level evidence that's cited in the NCCN guidelines, as well as the well-known collaborative study that was done combining the EORTC and RTOG post-op data from a much older era. And as you can see here, the EORTC eligibility was very wide, including PNI, LVI, low node, stage 3 and 4. That's a lot of patients in the old staging system. Margins and ECE, and the RTOG was restricted to margins, ECE, and 2 positive nodes. So all of these patients were potentially eligible for escalation to chemoradiation therapy in the post-op setting. And then going back and looking at this, a lot of people have asked, well, does this really apply anymore in the P16 HPV positive era, given that these patients behave so differently, and most of the patients in these studies were probably not the same profile. It's complicated to work out, but in a reanalysis of the 10-year results of the RTOG data, they estimated about 15 to 25% of the patients in this trial were HPV positive, and they could not find a difference in the outcomes in that subset versus the overall subset. So the eligibility in terms of the EORTC and RTOG data, at least at the time it was conducted in that era, still stands. And according to this, the adjuvant chemoradiation indications remain positive margins and ENE. In the NCCN, adjuvant RT is indicated for any advanced T-stage, end-stage PNI, LVI, or low nodes. And again, these are all extremely controversial in regards to whether to apply them to TORS-treated patients or not. But there's RT indications and chemo-RT indications. A big part of the controversy came out of some of the Washington University data, where they tend to use actually laser, not robotic. But the point is that when they went back and analyzed their retrospective cohorts in patients who had been treated mostly with standard therapy, and a good number of whom had received chemoradiation, what they found was that ENE was not a significant factor in those patients, keeping in mind that these patients were treated with traditional indications. And furthermore, within the ENE patients, there were some who were selected out not to receive chemoradiation, and there didn't seem to be a difference in those patients. So this controversial analysis has gone pretty far at this point, questioning the role of the chemoradiation according to the EORTC RTOG combined analysis, as well as what's indicated in the NCCN guidelines. I'm going to point to an alternative paper that was just published again in the Red Journal, which I think is useful reading for you. This is a paper that was a combined analysis from some major surgical centers led by the Mayo Clinic. And as you can see here, what they tried to do is go back and look at patients who had, for whatever reason, not received any adjuvant therapy after TOS. And for patients who had intermediate risk features as defined according to the NCCN, PNI, LVI, advanced T or N stage, and received no adjuvant therapy, the relapse rate at 3 years was 12%. And for those who had ENE, and that was defined as any, well, they sort of looked at subsets, but basically any ENE, even less than 1 millimeter, the 3-year relapse rate was over 50%. So these are patients that, for whatever reason, either refused or were binned into, kind of a better risk category. Just showing you, again, there is some selection here, but these are interesting numbers to look at what happens if you try to overly de-escalate with TOS. There is a question you have here, question 3, and I'm just going to advise you that to answer this question, as we just saw, patients who have intermediate risk features, going back to our slide there, have a 3-year relapse rate of about 12%, but the overall incidence of relapse in the entire cohort was more on the order of 26%. So the point is here that to answer this question properly, I would ignore the first part of the phrase there and look at what's the disease recurrence at 3 years in any transoral patient who does not receive adjuvant, and the number is somewhere in the range of the mid-20s. Among all patients not receiving any adjuvant therapy, 26% will recur at 3 years. In the intermediate risk group, that's probably on the order of 12%, at least in the selected series, and for patients with high-risk features, the rate is over 50%. It is important to note that patients who recurred after not receiving any adjuvant did have the opportunity for salvage 3/4 of the time. We don't know exactly what happened to those patients who were salvaged, but I will tell you in my own experience at my institution among patients who refused adjuvant therapy, the recurrences tend to be fairly aggressive with a lot more E&E. Okay, so let's talk a little bit about these patients after TORS, what happens to them. This again is that NCDB analysis of a lot of patients from 2004 to 2013, and again restricted to T1, T2 class. Why is that? Because TORS is approved, robotic surgery is approved by the FDA for T1 and T2, so that's why this group of patients is of interest, because they can be legally surgically treated. And as you see here, among these patients, 25% had E&E, 25% had positive margin, and 43% had one of these high-risk indications. Upstaging was seen in 25% of N0 patients. So the point here is that in T1, T2, N0 patients who might have been eligible for single modality therapy, a good number of them actually upstage to higher stage. At least a third of them have positive margins among this N0 class or E&E. And 50% of them have an adverse feature that now results in multimodality therapy. So the question is, what's going on here? Either single modality therapy historically delivered has worked for T1, T2, and N0 very well, and now we're discovering that maybe it actually eliminated some subclinical disease, or the patients who are being selected for TORS and being binned as clinical T1, T2, and N0 are not really that. So the point is that the authors of this publication state that although there's great enthusiasm for the primary surgical approach because of the possibility of limiting morbidity, we have demonstrated elements of suboptimal treatment selection that may ultimately lead to escalation of adjuvant therapy. And I think we've all seen that in our own practices, that inappropriate selection can actually mean that the patient receives trimodality. UPenn series confirms that in their major series of the 114 patients, 33% of these patients had E&E. And in the ECOG 3311 trial, which has just concluded enrollment and is maturing for analysis now for the endpoints, 31% of the patients in this study actually ended up receiving trimodality therapy with 66 grain weekly platinum delivered adjuvantly. What's the implication of that? Why do we sort of not want that to happen to patients? Because there is, I think what's actually been underreported and under-discussed, the necrosis risk after TORS. As we see the depth of resection getting larger and more extension into the major vasculature with ligation of major arterial supply to the base of tongue, we're seeing that these patients are experiencing non-healing wounds, which are pretty significant to deal with, I can tell you in my own practice. And there have been two really excellent studies from the University of Pennsylvania and then a lesser one from Japan that looked at risk factors for non-healing necrosis after TORS. The rate that was reported in the UPenn study was 28%, and it was 23.5% in the Japanese study. These were associated with various factors such as the depth of resection, particularly the dose being over 2 gray per fraction, and the development of mucositis. And you have a question there that's asking about the rate of soft tissue necrosis in patients who receive transoral surgery followed by radiation therapy, with the complication rate being associated with large fraction sizes, greater depth, larger CTVs in the range of 23 to 28%. I'm going to just show you now the ongoing studies in TOS that are evolving and challenging some of our traditional treatment paradigms, not yet complete, but just on the roll. The ADEPT trial, which is being run by Mayo and WashU, is basically looking at a comparison of patients who have E&E on pathologic review, whether cisplatin is warranted or not, with a 2-year endpoint. The PATHOS trial has not yet begun enrolling, but will enroll in the United Kingdom. This trial is a little complicated. The patients go into 3 different groups, much like ECOG 3311. The low risk gets no adjuvant and is observed, just like ECOG 3311. Group B, like ECOG 3311, goes into 60 versus 50 gray, and the high risk patients are randomized here with or without platinum to 60 gray, not 66. And so this is going to be a very complicated and large trial requiring probably 800 or 900 patients. Will enroll as a phase 2 and phase 3. And then finally, there are a couple of randomized trials that are directly testing the role of chemoradiation against upfront TOS. Orator 1, which is running in Canada and maturing now, is for early stage T1, T2, again, by strict FDA indications, at least clinically declared T1, T2. Without apparent ECE, but up to a high nodal stage for chemoradiation versus TORS, followed by adjuvant therapy. And the endpoint of this is actually a quality of life score on swallowing. The EORTC study, which is running in Europe, is a similar study, again, looking at MDADI. And these are basically toxicity endpoints to be able to power something larger and more definitive later. And then Orator 2 has, I understand, maybe is just opened or is about to open in Canada, run by the same group, London, Ontario, and Canada. And what they're using here, in a somewhat very cutting-edge way, is for patients, again, with T1, T2, and 0 to N2 disease. They're randomizing to the HN002 control arm, which is 60 gray with weekly platinum, versus upfront TORS and neck dissection, followed by 50 or 60 gray, quote-unquote, depending on risk factors. So this is sort of like, I guess you would call the best of the best, right? The best of the best compared to each other with an endpoint of PFS. I understand this is going to be 228 patients. Questionable as to whether that's enough to see changes in disease outcome or not. The use of transoral surgery is clearly increasing. Quality of life and cost effectiveness, I hope I've shown to you, are very sensitive to what type of adjuvant therapy is given. I do believe that suboptimal selection persists and is borne out now by our large national databases, which are showing patients who are outside the FDA indication or outside what might be considered traditional selection factors. The intensification of adjuvant therapy on these patients may lead to complications that can be severe. And the trials right now, as I showed you, are assessing both whether that adjuvant phase can be decreased in an effort to improve the quality of life of these patients for the overall program, and also whether the best of the two regimens can be reasonably compared. Thank you.
Yeah, one is for Francisco. All right, so thanks, Sue, for that. So we're a little bit out of order here, but so next, there's no better person to hear about transoral surgery than from a surgeon. So Francisco Cervantes is an ENT at the University of Miami and co-director of the head and neck surgery program there and an expert in transoral surgery. So Francisco will give us his thoughts about transoral surgery for oropharyngeal cancers.
Thank you, and good afternoon. So our previous speaker covered a lot of important material, so I'm going to be able to go quickly over some things. But oropharyngeal cancer, as you know, is increasing in frequency, and there's approximately 9,000 new cases a year at this point. And tonsil is more common than base of tongue. Both are increasing, and the standard of care has been chemotherapy with radiation. The standard of care before that, when I was in training, was surgery, which was open surgery, followed by radiation. And that shifted because of the morbidity of the surgical approaches that were being used. Patients were having composite resections with mandibulotomies or pharyngotomies that had a long swallowing recovery. Really, for tongue, base, and tonsil, you really don't need to do mandibulotomies, despite the fact that that's often stated, oh, we're avoiding a mandibulotomy. In fact, back then, they just hadn't figured that out. But there's open approaches that allow us to take out oropharyngeal cancers that are used for recurrences primarily at this point. But these approaches have long swallowing recovery. And so that gave way to chemotherapy and radiation, which became the standard. And now TORS is being introduced, and we're still trying to figure out how to use it and what it means, and if we do TORS, what do we have to do after. So that's all being figured out. But we do have good data on the oncologic and functional outcomes of surgery prior to the TORS era, be it laser or open. And we know that the combination of surgery followed by radiation is extremely powerful for either advanced disease or early disease with high-grade features on pathology, and that either surgery alone or radiation alone is often very effective for early disease that doesn't have high-grade features. One of the things that is difficult to handle is that we get more information when we do surgery, and then we don't know what to do with that information. So if you don't operate, you never know that that patient had extracapsular extension, so you don't have to give chemo. You can radiate that patient with a T1 tonsil or a T1N1 tonsil. But if you now do surgery and told the patient you're not going to give chemo, and then you get minimal extracapsular extension on that node, all of a sudden now you can't talk your radiation therapist and medical oncologist, talking from the surgeon's perspective, into not recommending chemoradiation. But that patient would have gotten radiation alone, and in theory, surgery followed by a post-op dose of radiation logically should be enough, because they would have gotten radiation alone. So we're doing things that are not logical, and we're just not thinking it through completely, with all due respect to all of us. So, and we're doing it because I think of medical legal concerns often, and standards that have been established in the literature. So it's almost too much information. So anyway, we do have good data from the past about the role of surgery, often with adjuvant radiation. So now this new instrument comes about, and surgeons are kind of discovering what they can do with it. So the benefits of the robot are that there's no line of sight issues. You can look around corners. You have three-dimensional visualization, whereas when you're working through a telescope, for example, laparoscopically or what have you, or when we use a zero-degree telescope through a laryngoscope, you have no three-dimensionality to it. If you use a microscope, you're in 3D, but you have line of sight issues. You can't look around corners. And you have wristed instruments, which was a new thing. When we do laryngoscopic surgery, we have long instruments that are, 8 inches long, and we're working with them, and you don't have as much control on the tip. And now you have an instrument that's wristed at the tip and can do. It's like a little hand, so it's pretty amazing. And you guys have heard all this stuff already. It gets rid of tremors, so when surgeons get old, they can keep operating. It's important. So it's also a great marketing thing for surgeons, and that's a problem, because that shouldn't be part of the discussion, but it is. And all of a sudden, surgeons who never did cancer surgery are doing robotic surgery for tonsil cancer. And if you don't do the open surgery for salvage when the patient recurred after radiation, you probably shouldn't be the one doing the robotic surgery. That's my bias, but that's not what's happening. So this is the setup of the room. The details are probably not that important, but you can see there's a mouth gag. There's a bunch of instruments. And the robot is brought up to the patient's mouth and positioned, inside the cheeks, and there's a telescope and 2 arms. The benefits of TORS compared to open surgery would be shorter hospital stays, shorter operative times. The learning curve would be a negative. You can't just pick it up and use it. You need to be trained. But there should be a faster return to normal function without disfigurement, and usually you can avoid a tracheostomy and a PEG. I'm going to present a case where we did a tracheostomy, but that's an unusual situation. It's safe, efficacious. Usually the blood loss is minimal. There have been rare catastrophic bleeding cases, and technical improvements have almost completely eliminated those. We had a very bad bleed in our service about 7 years ago. We adopted the technique of ligation of lingual artery and facial artery during the neck dissection and have never had a bleed since. If you are taking out a tumor in the mouth without operating on the neck, which usually isn't the case for squamous cell carcinoma, but for some other rare histology could be the case, then you have to be really careful to see the vessel, double clip it, because you don't have that advantage of having ligated the vessel in the neck. But as far as squamous cell carcinoma goes, we're usually doing a neck dissection, and when you do that ligation of the vessels, it really makes a huge difference. So you may have a minor bleed if the patient is, especially if the patient is on an anticoagulant, which so many are, and you reintroduce the anticoagulant, that's an issue in some of these patients. But a major bleed from a major vessel is an issue that's been almost eliminated I mean, in our service, it's been eliminated. It's never happened since. I assume it's not impossible, but we haven't had it happen in the last 7 years since introducing those modifications to the technique. And the same thing happened on ECOG 3311, and with the same result, they had a catastrophic bleed in their first 50 patients. They introduced a requirement that surgeons, the patient didn't pass away, but I think it was a near miss, and they introduced a requirement for arterial ligation of the lingual and facial artery during the neck dissection, and there were no more problems after that. The old way of radical tonsillectomy, actually, for a lot of the tonsil cancers, really could be done, but for patients that are a little more difficult to see, the robot makes a big difference. For tongue base, the robot makes a big difference. When you're doing robotic, it's not exactly a tonsillectomy. You're taking the constrictor muscle. The carotid artery is covered only by a little fat pad. It's in the field. Improved visualization is a good thing. It's useful. So this has made it easier to offer transoral approaches to more patients. So these are the steps in a radical tonsillectomy, which, as was stated, is FDA approved for T1 and T2 lesions, and you really shouldn't do it for T3, T4. So this is a good time to editorialize on this. The TORS procedure is the radiation oncologist's best friend because you want your patients to have good function, and so for the right patient with the right selection, you're going to do a procedure that has the side effects of a tonsillectomy, which is no long-term side effects, only short-term pain for a week, and then that's it. And then you're going to reduce your radiation dose, so you're going to reduce your radiation side effects. But in the wrong patient, then you're going to have side effects from the surgery, and the whole premise is gone. So if your surgeon operates on a patient with too much soft palate involvement, or a tongue-based tumor that crosses over the midline and is too big for TORS, then all of a sudden the whole premise of the surgery so the whole thing is based on the concept that the surgery is not going to increase your side effects, and then you're going to reduce your radiation dose. And so it should be done for T1, T2 lesions, unless it's a unique circumstance, some non-squamous histology, something unique, there's an argument with the P16 negatives as to whether maybe surgery should have more of a role, since we're not getting as high cure rates with the chemoradiation as we are for P16 positive. But certainly for P16 positive disease, the whole thing is based on the premise that surgery is not going to add to the side effects. So, patient selection is extremely important. It should be T1 and T2 in the right location and not in the wrong location. But this is the operation you're going to do for that properly selected T1 and T2 lesion. There's a buccal mucosa incision, a dissection laterally deep to the constrictor muscles, that being basically the middle and a little bit of the inferior constrictor, and maybe a little bit of the bottom of the superior constrictor, but primarily the middle portion of the constrictor muscles at the level of the oropharynx. You're going to dissect off of the styloglossus. You're going to divide the styloglossus and stylopharyngeus muscle, and you're going to have mucosal cuts behind the posterior pillar, in front of the anterior pillar, across the tongue base. And then at the end, you're probably not going to need any reconstruction, but if you took a little more of the soft palate, you'll pull some buccal fat in to reconstruct that. To ensure that you don't get velopharyngeal incompetence. If you've properly selected your patient, that won't be an issue. This is the anatomy that you have, and the carotid artery being the most important structure that you have to make sure to be cognizant of. And since you're in 3D, and since it's really not that close, and there's a potential space between it and the tonsil, you should be fine. But if you're in a teaching institution, you definitely want a teaching console, and you want the ability to switch the controls between the two surgeons, which is what we have. Because if you're sitting at the head looking at the TV screen in 2D, you can't tell the depth of the trainee. So we have both the surgeon and the trainee in 3 dimensions, and complete ability to switch controls, and that to me is super important for those of you who work with surgeons who are involved in training. The hypoglossal nerve and lingual nerves would be important structures. One, especially if the tumor gets a little closer to the retromolar area. The other one sort of at the depth of the resection in the tongue base. So patient X. This was an interesting case to me on many levels because it presented some difficult decision making. So this isn't the standard patient. This is the one outside the box. So this gentleman is 59 years old, and he's obese. He probably weighed about 270 pounds, something like that, not that tall. Came in with a T2, what I called N1. Now, it was extremely exophytic. I think the CAT scan on the left gives you a sense for how exophytic this tumor is. That's the PET scan. And this is not actually him, but this gives you an idea. This is probably a little bigger than what he had, but extremely exophytic tumor. You could put your finger on it and move it around. You know, it was a ballotable, exophytic tonsil cancer, squamous cell carcinoma, P16 positive, never smoked. And so we presented him at conference, you know, with our radiation oncologists, medical oncologists present. And the problem with this guy is he had really bad sleep apnea, and he was on anticoagulants because of hypertension and diabetes, and so they put him on. He'd had an MI like 7 years before, and so they had him on what's the new the new anticoagulant that everybody's on. So instead of Coumadin. So blanking on the name. So anyway, what's that? Yes, Eliquis. So he's on these medicines. So I present him at conference, and the usual way I handle a patient like this is, listen, you're not a great surgical candidate. You have sleep apnea. You're on an anticoagulant. Let's give you chemoradiation. And the radiation oncologist at the conference made the point. He said, listen, with all that exophytic disease, I can really reduce my volume if you take that off, because otherwise the posterior pharyngeal wall behind all that exophytic disease is going to get dose. I hope I'm not saying something wrong, but you guys know better than me. If what I said doesn't make sense, forgive me. But that's what I was told. So we said, there's other features here, particularly the exophytic nature of this disease, that make this a really good candidate for surgery. And he's T2. He was a borderline T2. It was a little smaller than this. He was maybe 3 centimeters. So we. I think he was about 3. He was at the upper limit of T2 actually. So we said, okay, we're going to do surgery, but we did a trach on him because we knew we were going to have to start anticoagulants, and because he had sleep apnea, and you cannot use a CPAP machine in the post-op period, because since you've opened that area, so this is a little interesting tidbit, you will get sub-Q emphysema up and down the neck if you put a CPAP machine on after doing TORS. Now, we learned that with a previous patient many years ago. Okay, so we knew we couldn't give him his CPAP, so we put in a trach. We took it out, 2 weeks after when his tonsil fossa was healed. So that was something that you don't normally do, and it turned out to be a good call, which is of course why I'm presenting it. He was enrolled in ECOG 3311, and he actually turned out to be 4.1 millimeters when they measured it on the path report. So they called it T3, but the node that we all felt was just a prominent jugular node that was not actually cancerous. So he turned out to be, despite being staged as T2N1, he turned out to be T3 and 0, and ended up getting no further treatment because he had widely negative margins, because the T3 was based on an exophytic thing, but the base of the thing was probably more like 3 centimeters. But apparently the staging really goes by the size of the exophytic tumor, not by the base. So he was still considered T3, so he needed no treatment, and it's been 2.5 years, and he's still doing well. So this was the ultimate surgical case, other than his sleep apnea, and not medically it wasn't the ultimate surgical case, but in terms of tumor characteristics, it was the ultimate surgical case. Hence, we pushed it despite medical contraindications. So let's talk about TORS now for tongue base. So a little different from tonsil because the borders are less well defined. Generally, you use the circumvallate papilla as your marker for your anterior cut. The disadvantage to open surgery is you can't palpate when you're doing TORS, and so you tend to use the imaging and the anatomic landmarks and take very wide margins. You use the circumvallate papilla, the midline, and then the glossopharyngeal sulcus. Take as much tonsil as you need. Take care not to hurt the lingual nerve, and trace the dorsal lingual artery, which you can see in this picture here somewhat, although it's kind of small, and it takes you to the lingual artery, and you got to remember to watch and not hurt the hypoglossal nerve, which if you're not doing a huge tumor that you shouldn't be doing, you probably won't get near the hypoglossal nerve. So patient selection, again, is the way you avoid complications. Generally, when I do these, I'm intermittently going traditional and robotic so that I can sit at the patient and palpate, then go back to the robot. And the robot is most useful for the vallecular part and the posterior part near the larynx, which is hardest to see with traditional technique. So, contraindications to TORS surgery. This is going to be one of your questions. There's relative and absolute. So these are absolute contraindications. Unresectable nodal disease, mandibular invasion, more than 50% of the base of tongue, need to take more than 50% of the posterior pharyngeal wall, carotid artery involvement, fixation of the tumor to the prevertebral fascia, inability to visualize a patient with very bad anatomy, tiny mouth, tiny throat, inability to extend the head because they've got spine disease, something like that. And a retropharyngeal carotid with the surgeon should have checked on the imaging for the retropharyngeal carotid, because you don't want your carotid sitting there exposed without fat on it. You at least want a nice fat pad on it. So those are the absolute. But then there's some relative. What are the relative ones? Well, T3 is a relative. Contralateral nodes is a relative, because now your operation got bigger. You got to take out the others. Not that you can't do it. So maybe for a P16 negative, you'll offer that to the patient, but that's such an infrequent thing in South Florida. Everybody's P16 positive. And in other parts of the country where they're still dipping tobacco and all that, they still see tons of P16 negative. But I don't see much P16 negative. I get excited if I see P16. Everybody talks about it. But for the P16 positive that is the bulk of what I see, you wouldn't want to do T3. You wouldn't want to do it if you had to do bilateral necks. You wouldn't want to do an N2 because you've got such a favorable histology for chemoradiation. You want to pick one that's N1, real clean for surgery. Now, if you get into a disease that is not as chemo and radiosensitive for whatever reason based on the histology, you get a patient with some strange sarcoma or something like that, then obviously these are the absolutes where you go to open surgery. So these are the absolutes where you can't do TORS, go to open surgery, okay? All right. So there's been a lot of studies confirming that you can get adequate margins. And I was interested in the study that was mentioned by the previous speaker that had a high rate of negative margins. The published data from Penn, they almost never had positive margins. You chase your margins, you get frozen sections, we never have positive margins. I think that happens once in a blue moon, maybe 1 in 100, when you get one of these patients with extensive unexpected lymphovascular invasion, where you cut a mile away from the tumor and you're still getting lymphovascular invasion. Am I getting near the end here? All righty, all right. So what I'm going to do, since a lot of the data has been presented by the previous author, is I'm going to, by the previous speaker, I'm going to just kind of go on and summarize this by saying that survivals are equivalent for properly selected patients in terms of oncologic outcomes, and swallowing outcomes are very good for patients who are properly selected, and that when patients receive surgery alone, their FOS score, their functional swallowing scores, go back to normal when you treat a patient with surgery alone. So we know it's all a matter of which adjuvant therapy they get is what's going to affect their swallowing. The only time it wouldn't is if you went to patients who shouldn't be getting surgery, especially too much soft palate involvement or too much tongue base involvement. It's all, what we've got to figure out now is on these P16 positive patients, what adjuvant therapy do we really need to do? If it's minimal extracapsular, do they really need chemotherapy, et cetera? All right, and you're all familiar with ECOG 3311. Let me come back to my, you're all familiar with ECOG 3311. I just wanted to mention we're going to be getting a lot more information from ECOG 3311. We're going to get normative data. We're going to get a first hint as to whether we can de-intensify a little bit. So this study basically involved TORS for T1, T2, N1, N2 tonsil cancers, and the de-escalation was in the intermediate risk group. So patients who did not have extracapsular extension were randomized to get either 50 or 60 gray. If they had extracapsular extension, perineural invasion, something like that, they went on to get the usual post-op radiation or post-op chemoradiation. And patients who turned out to be N0 accidentally didn't get any adjuvant therapy. And I think N1 without extracapsular extension also was treated with surgery alone. So we're going to be getting a lot more information. And in conclusion, TORS has a role in the multimodality treatment of selected oropharyngeal neoplasms. Patient selection is key, similar to other organ preservation approaches. Early data regarding oncological and functional outcomes is promising. Now, I have 2 videos. Do you want to show them, or you?
So I think for the sake of time.
Yeah, all right.
So, awesome.
All right, thank you.
All right. Thanks so much for that. So, for the sake of time, we're going to keep moving on. So now we're all experts in TORS and what that means. So say we have a patient now who has an indication for adjuvant therapy. So Dr. Lee is going to talk to us about how we should be thinking about that.
Thank you so much, Michael, and thank you so much for having me. If you haven't been confused, I'm confused. So here, I have nothing to declare. I think we're living a confusing time. And this is a paper, and Sue is one of the co-authors for this one disease. You have so many options depending on where you go. Basically, look at the recommendation. You go from RT alone, CCRT, TORS, from adjuvant. All over the place, we are all very confused. And I hope at the end of the talk, I can shed some light. Then I want to look at a different approach, de-escalation. And I was asked to put in some proton slides, but if we run out of time, we'll skip those. TORS, I think we should look at this population study. There is a 67 increase in the use of TORS, and I think Sue talked earlier on another study too. TORS are more likely in academic centers, have private insurance, HPV positive, less likely in the West Coastal rural area. TORS are less likely to have positive margins, and adjuvant concurrent chemo-RT is less likely with TORS. High volume centers less likely have unplanned remission. So in Dr. Cervantes, Francisco's hands, that's true, but not everyone should do TORS. If you hear anything from him, not everyone should do TORS. We need to standardize training and monitor nationally. We've done that for radiation. The surgeons have to do that, and we are doing that in the energy oncology. This is a trial, very interesting trial about various PI. To me, the RT volume is still quite large. I mean, I opened that trial in my center. I wound up escalating my volume. Surgeons don't understand. It's not just the dose, it's what we target. So I have personally bias for that. But I think the most interesting is, can we select out a group? If you heard both speakers say, patient selection. If we select the right person and just do TORS and don't do anything else, I don't want to give that person radiation. The person's 40 years old, 50 years old. We're going to give toxicity no matter how much we de-escalate. So I hope that that is the winner, although I am worried about the retropharyngeal region and what's been published with the, if you don't give adjuvant, what's the risk of recurrence? So data will tell us. So in our center, and you know, you get patients come in, they're not eligible for trial. This is why we wrote this trial. Jillian Tsai is our PI. And basically, it's an adaptive program. Everyone does replanning for radiation, right? Or you choose select patient. What we did was we made RT volumes much smaller than ECOG 3311. So to me, functional outcome is going to be better. Dose is less. We're already giving our subclinical 30 gray, borrowed from other disease sites. When anal cancer, we treated 30 gray to gross disease. We don't give induction chemotherapy like the way University of Chicago does, a lot of induction, then gross disease only, nor do we need surgery. It's very easy to implement any clinic. Everyone gets chemo-RT. I'm a big believer of chemo in especially the high-risk patient. I'll show you data later. You can have IMR2 proton. So hopefully when this data is presented this year and that it's published, that it can help you in the average clinic to practice. You don't need, if you're a candidate not for TORS, there's no induction, it's easy to implement. And that's why we did that study. Now, looking at post-TORS RT indication, I think one of the questions is, when do you give chemoradiation? Currently, it doesn't matter how little your ECE, extracapsular extension is, you need to give concurrent chemo-RT. Until there's more level 1 evidence, we are going to give concurrent chemo-RT if you have any evidence of extracapsular extension or you have positive margin on ink. Oh, I need to say this. Very tempting to de-escalate. I run through that too. Surgeons will twist your arm, push you, everything. Tell the patient, oh, you're getting low dose radiation. Do not be pushed. Do not do anything outside the standard care, outside of a clinical trial. We're going to hurt patients. These are curable patients. Every case should be discussed in multi-D fashion. Every Thursday morning under Rich Wang's leadership and other DNT, myself and David Pfister, 7:30 to 8 a.m., every one of us get there early in the morning. We discuss every HPV positive oropharynx cancer, everybody. And then we drop the incidence of TORS. Before, we have 5 TORS surgeons. People just did they saw fit. And then now everyone has to see one of us before we present TORS. I think that's the right approach, a multi-D fashion, because then you can pick out the RP region that Francisco talked about. Maybe you see some lymph nodes there. You shouldn't go and do TORS. Now, HPV positive is so important that we change our staging system. As you know, it's implemented this year. We should do that. But just because you're stage 1 doesn't give you a ticket to de-escalate and say, oh, I only need unimodality treatment. Staging does not change your treatment. We're still collecting data. Remember that. Don't just say, oh, stage 1, I don't need to give anything else. And it's important because I really like this paper by the Yale group, Ben Judson, who was one of our former fellows, and published in Cancer December. I encourage you to read this. And he used a new staging system, stage 1, 2, 3, based on AJCC 2018 staging system. And then may need more, and the conclusion was maybe you need more than unimodality. Concurrent chemo-RT is still better for the new stage 2, which is the T3N2 disease. Triple modality did the best, your T4 and 3. So the reason he said de-intensification from chemo radiation or radiation alone or surgery alone for stage 1 or 2 may compromise patient safety. The bandwagon's out there, everyone to de-escalate, but remember, these are the patients that we can cure. And do not do something that harm your patients. And this is the data. For stage 1, look at this. RT alone didn't do that well. Surgery alone, this curve didn't do that well. It's really, you need something else. And now, I'm not saying T1 and 0, which is included in stage 1, go and do double modality. Select your patient correctly. Think about your intermediate risk factors. Don't just go in and say that's all you need, one modality. And then for stage 2, which are your T3 and 0s, surgery plus CCRT are probably the best, and or concurrent chemo-RT. The other modality single is not good enough. And for stage 3, and I think, these are the T4 and 3. I mean, I'm sure the people that got selected are highly selected. And we all know there are T4s and there are T4s. Right? There's T4 minimal invasion to the base of the floor mouth, and there's big Goomba T4. So staging alone is not good enough. It's good, but it's not good enough. It's not all your answer. So how about dose? It's all over the place. I actually, for this talk, I don't have a talk. So Michael, I told Michael and Sue and everybody and Francisco, I had to put a talk together. So I went and I PubMed and I had this amount of papers about TORS, and all over the place. Let me just summarize for you. It's all over the place. But 60 to 66 gray is the most popular dose schema in the TORS literature, and to me, it is the current standard until we have more data to de-escalate. Prefer fractionation, 2 gray per fraction. Sue already talked about this issue of soft tissue non-healing necrosis. They eventually resolve, but patients are miserable. Dose per fraction is very important. And this is a UPenn data Sue talked about, Korea and the Japanese data, around 20 to 30%. And size is important, depth is important, tonsil more likely. They do heal, but it takes time. What I want you to take home point is do not give greater than 2 gray per fraction. You're gonna run into a problem. That's a pretty consistent message. Now, I want to talk about de-escalate. If you're going to de-escalate and you want to do TORS, just do it. I like the Mayo Clinic way. They really, extreme de-escalation, aggressive de-escalation. This was presented at ASTRO and ASCO. They took P16 positive patients. They divided into 2 cohorts. They did a 1.5 BID to 30 gray, borrowed from the NIGRO protocol. We used to cure an anal cancer with 30 gray with chemo. And if you had ECE, you gave a little escalated RT. And their overall survival is excellent. It's 80 patients, and then progression-free survival, very nice, and then local regional control. But this is done on trial. The point is so good, and here's the volume. You can see patients without ECE, if the other neck wasn't touched, they won't radiate, which is pretty standard what we do, right? The upper high neck, you don't have to contour the contralateral neck, but if you have ECE, start thinking crosstalk between the two necks, you should cover the other side of the neck. And then from that, they have a randomized ongoing trial comparing against Sue's standard arm, which is really a phase 2 randomized study. And Sue and I know that, we all know that, but that's probably gonna be the standard care because we're never gonna do a study comparing to 70 gray. But it's like, that's the way it is. Everybody compared to 60. I'm a little worried because I do think these patients do live. Now, I was also charged to think about post-op volume. It's very interesting. Go to talk to the robotic surgeons. They go there and they're like, we never contour our post-op bed. We omit the primary. And you and I both know that we are not good enough with IMRT. We're gonna spill the dose to post-op bed. And this is a study that Mount Sinai group did. And very nice. They looked at no difference if you contour the post-op bed or not. In fact, when you didn't, look at the dose. You're still getting dose to the post-op bed, even when you try to omit it. The surgeons didn't realize this. Oral cavity dose was the only one that probably differed, and the superior constrictor muscle differed. But there was no toxicity seen between the patients treated. The recommendations do not omit the post-op bed, which limit the options for salvage. At MSKCC, we always get the post-op bed. In fact, when the surgeon touch an area, that tissue is violated. I'm gonna target, because you never know. It's not their fault, it's just that it's been touched, and something that could be seeding, and we have seen that. So now I wanna end by looking at a personalized approach, because listen, we can sit there and talk about tours, we can sit there and talk about RT, we can argue the world is much bigger. This is precision oncology, 2018 going beyond. We need to be more personalized. We need to select right. Is de-escalation needed for all patients? Is it for all patients? The answer in my mind is no. We gotta go back. Look at this patient with a survival curve. This is a cell line, HPV positive. They're just as bad as this HPV negative. So if you de-escalate this patient, you're gonna run into trouble. Instead of focusing just on smoking, which is done by an RPA analysis, we focus on the biology. Biology always trumps anything, staging or smoking status. And here, HPV positive radiosensitivity, I encourage you to read this nicely paper done by one of my colleagues looking at different reasons why HPV positive tumors are radiosensitive. I'm gonna look at hypoxia. Hypoxia is important. I think everyone in the audience knows there are tons of paper on hypoxia. Hypoxia tumors are bad, preclinical, animal, and in patient across all disease sites. And this group in Europe looked at their cases of HPV positive tumors. If you had hypoxia, you did bad. Look at it. If you didn't have hypoxia and you had HPV positive, you did well. But if you had that other factor, which is hypoxia, which is lack of oxygen, you did just as bad as an HPV negative patient. Are you going to de-escalate that patient? Probably not. So they look at independent multivariate analysis and looking at HIF1 alpha, which is a marker of hypoxia. It's bad. 1.588-fold hazard ratio increase in risk recurrence. And then when they look at univariate analysis they only have 44 patients with HPV positive tumor, hypoxia expression increase your risk of recurrence by 6-fold. So it is important. So what we did at Sloan is we looked at a way to measure hypoxia by looking at hypoxia imaging, measured by 18-fluorimidazole. If you have baseline hypoxia and then you resolve, maybe these are the patients we de-escalate. And thank you for Sue for allowing us to publish our paper in Red Journal. 60 gray, when we did that approach, HP positive, that resolved first week into treatment. That tells me this patient's radiosensitive. Good enough to go to 60, 100% local control. So then I started thinking, why? How low can we go to make a meaningful difference? 10 gray is not gonna make a difference after TORS. And then this is our good friend ACRO, who 30 gray. Remember in our training, 30 gray was enough to cure HPV positive anal cancer. And now with HPV anal, HPV oropharynx, biology always trumps site. So that is why we did this schema, and we do include surgeons in there, and I love it because we all play in the sandbox together. They take their tumor, and I ask them to leave their lymph node behind. I can do all my sequencing, find out about the tumor. We follow them. We gave these people, select patients, 30 grade with platinum. The reason I think platinum is important is because I think there's only one thing we need, one weapon we have, unfortunately, systemic therapy to combat distant metastases. This is how our patients are feeling. It's not local regional, it's distant. So I think until we have more data to show distant recurrence is not important, we need to keep platinum. That's my own personal view. And then we follow these patients, look at the difference, 30 gray, 70 gray. I don't need to tell you, this is lower than lymphoma dosing. Weight loss difference. And then look at this waterfall plot, pathologic response. A gross node could be 6 centimeter. And then if you, 5 centimeter, sorry, and then it grew because you worry about, in these HPV positive tumor, they grow in big, small, right? Because that's virally related. And then we found so many people with pathologic CR, some people didn't, and we're trying to figure out why. And this manuscript is in preparation. We wrote this non-inferiority trial, and my goal is to ask the FDA for a specific indication. If MISO is actually commercially available, you can do it at your center. It's just a tracer. So I'm hoping that we can really de-escalate, for patient, in the right patient. And this is my target volume. You can see I get the post-op bed. And then I give a little margin because I am worried, and the MRI really tells you, this is PTV margin volume, just so you know. And then you can see MRI really tells you that there's tissue plane violation, CT may not. Don't compromise on your volume. And this is another, as lower down, you can see all this imaging changes so that and we're only giving 30 gray, so you need to make sure you're big enough. And here again, another one. And during our question and answer session, we can go over volume. And this is a typical view. I still like my LAN because I can block the larynx. Nothing is better than blocking it. You can use IMRT, you're gonna get about 20, 30 gray. But if I block it, it's 0 dose. And then I just do that. And the patient has very minimal toxicity. And then HPV positive disease is upregulating PI3 kinase. And I just want to share with you this patient, we're trying to get away from platinum. This patient had BYO, which targets PI3 kinase. It's an inhibitor. 8 days of radiation, look at it, lymph node gone. 34 gray, around that 30 gray. Look at pretreatment, gone. This is our restaging PET. So this is my mind. I want to end by this slide. This is the future because we gotta personalize treatment. We can't exist and keep thinking about surgery, radiation, chemo. Select the right patient, tumor profiling or imaging, and then you can have different buckets. Immunotherapy is hot, right? We know that. Maybe some people don't need platinum, so you have a systemic de-intensification depending on which profile you have. We already have the model of radiation de-escalation to 30 gray. I think that's the approach that we should take. So I'm gonna end, forget the proton because we are running out of time, other than it's an aging population, and we can talk about that later. I want to end by saying that, right here. It is a confusing time. Believe me, I'm just as confused. In New York City, patients come with stacks of paper. My 1 hour consult sometimes become 2 and 2.5 hour consult. Some of the patients know my data better than me, my cursor, and then I'm like, oh no, did I write that? I don't know. So basically, you spend a lot of time talking to them. They're very smart. And I'm sure you experienced that. Very confusing, but I really plead to the audience and I remind myself, do the right thing for your patient. These patients are gonna live. Do not hurt them because when HPV positive tumor recur, they recur like vengeance. We try to salvage many and it's very hard. Discuss your case in a multi-D fashion. Talk to your surgeon if you don't have a multi-clinic. Call your surgeon, talk to him, ask him what he's concerned about. And your med-onc, work as a team. And hopefully the panel phone can help you answer your question. And if you have any question, feel free to email me. My goal in life is really to help as many patients as possible. I don't want to see these patients who otherwise can live be hurt because we are trying to de-escalate with no data. Thank you for your attention.
All right, so we have about 10 minutes left in the session. I know that you see a contouring pearls listed there, but I think for the sake of time, and I know there's probably questions out there, so why don't we just go to some questions and... So any questions?
I'm afraid to hurt someone. Okay, wait, which one?
It's far.
Oh, no, I can't.
Ready?
Where is it? Nancy or anybody in the panel, can you comment on the need of adding chemo to minimally extracapsular extension in view of a couple of papers that they said you don't need it and we couldn't get it from our TOG?
No, I can answer that. You absolutely have to. That's a retrospective study.
It's not working.
Well, oh. You definitely have to. As of now, the standard care, you have to, it's one of your questions too. You have to add chemoradiation. RTOG, Energy, ECOG 3311 is trying to gather that in a prospective fashion. And also, I know there's some papers out, especially from Bruce Hoey's group. I think that's retrospective. It's hypothesis generating. It's great. It's good to know. But even if you talk to pathologists, they can differ on whether a patient has ECE or not, what's minimal or not. So I think right now, if you see ECE, give chemo. That's my take. How about you guys?
But there's a question.
I think it's important to remember that the patients who've been reported in retrospective series were treated for the most part with conventional treatment. Okay, so you're looking back at patients who, for the most part, got chemoradiation. I showed you that the rates are as high as 35, 45% in those post-TOS series got chemoradiation. So it's challenging to go through, and there, as you saw, the series reporting no adjuvant are very scarce. But the Routman series is 50% recurrence in selected patients who didn't get adjuvant, who had positive margins or E&E. And I think the other thing that's very confusing is that E&E has not been defined clearly as to marginal E&E versus gross clinical E&E. As of now, in the current 8th edition AJCC, it's very confusing because clinical E&E has to be defined as fixation with like skin involvement and like all this stuff. Very hard to, I'm not even sure most people in this generation are capable of doing that kind of clinical exam to define clinical E&E. But pathologic E&E is any E&E, even less than 1 millimeter. So we are going to have several years where I think this will be very difficult to resolve. And then as I showed you, there are a number of clinical trials that are testing the omission of chemotherapy for patients with E&E, but those trials have not even, in most cases, begun or substantially accrued yet. So in the absence of better data, the level 1 data remains the combined analysis, and I understand that that's really hard for people after your patient went through all this surgery, and now you're the heavy, and you're the nasty person who comes in and says you have to have chemoradiation and they don't like you. And that's why I explained to my surgeons it's really important for you so that we have good relationship with this patient, so that the patient is not upset with their total course of treatment, that you lay this out at the beginning, that this is a possibility. Because otherwise what you're setting up is dysfunction on the team. I think that's really, really important. And because of that, my team has maintained good equanimity with all patients, even when they have an outcome that's not desired by the patient or anyone on the team.
Great. Question back there?
Hi,
Yep.
thanks.
Francisco wants to answer.
Oh, sorry. Go ahead. Sorry.
I did want to weigh in on that one. I think it's very, very possible.
I don't think
change
you're-
in the
is your-
next 10
Oh,
years.
you have press
His
that.
mic is
press.
I think it's very possible. Is it working?
There.
Use
No.
mine.
I think it's very possible that will change in the next 10 years, but I agree that it has to be hypothesis driven. I think it's important to realize that there is a mixed bag in terms of the HPV positive patients, and some are more aggressive than others. I think if you have a pure case where it's a non-smoker who's HPV positive, it's very possible that when studies that are being done now come out in a few years, that these patients will not be needing to get chemotherapy. The radiation is a separate issue. Absolutely, they're going to need radiation. I mean, there's no doubt about that. So to do surgery alone is not going to be an option for those patients. But I think that you're going to probably be looking at de-intensified radiation and no chemo for patients like that who are HPV positive. But I agree 100% with what was said. We can't create a free-for-all. We need to stick to the standards, because then if the patient recurs, terrible things will happen. And we've all had our recurrent HPV positive case that died. We've all had that one. So and it's usually a smoker, but who knows? So I agree with them with that caveat to keep watching the literature and keep an open mind.
Okay, great. So going back to Blue.
Thanks. First of all, I want to thank the surgeon for joining a radiation oncology conference. It's part of head and neck, and it's so valuable. Thank you for being here. But I also want to second this idea that we do get a lot in my tumor board. The surgeons are asking me to leave out the primary site all the time, and leave out the contralateral neck when we do an oral tongue, things like that. But also the newer thing, and I wondered what all of you have experienced, is, with the new staging system, there's a push to stage the patients and then also treat them as stage 1 or stage 2. What do you guys say in response to those things? Same thing? Wait for data?
No, actually, the staging system is based out of the ICON study that Brian O'Sullivan did, and then we specifically said that we do not change management based on staging. It's really just to show you that you can separate out more, but still look at your T and N. And that's why, just because it's stage 1, the new staging system, like a T2 and 1, that doesn't mean just unimodality. So we have to be very careful. That's my concern. Actually, when we wrote the ICON paper, that is one thing we're worried about, that by writing this paper, people will start doing unimodality because, that's what ICON said. But that's not the goal of the paper. And in terms of the primary, I think if we're going to do it, and maybe you don't need to treat the primary, then you need to use proton, because then you can really limit. That's the only way to test it. IMRT, just Francisco, it splashes all over, because by the time you treat in the neck, you can't avoid it, even when you try, especially if you have to do the other side of the neck too.
Right. Any other questions? Right here in the front.
I
Sorry, go ahead.
add to that. That the staging system is prognostic. It's like telling you what will happen if you treat a patient of this stage with current standard treatment, right? So it tells you what happens to that patient if you give them traditional treatment. They're going to have a very good outcome. It doesn't tell you what's going to happen if you give them something less. And I sit here speaking as, the driver of a de-intensification study. And I want to make clear that HN002 was not based on some idea that just because these patients do well, let's give them less. That's really not the thinking. The thinking was, we're seeing that these patients respond very early in their treatment course. We're seeing that many of them have complete responses by the end of therapy, or even as soon as 2 weeks later. And so there's clearly some increased radiosensitivity, not to mention the biologic evidence that come out from several labs showing HPV positive tumors may have changes in DNA repair, which make them more sensitive. That's the basis for the de-intensification effort, not just because they do really well. Doing really well is great, and we want them to continue to do really well, and that's why I also feel de-intensification is an issue on trial. Whether that is de-intensification, I'm kind of agnostic about this, via radiation approaches, via surgery, via adjuvant radiation approaches, it should be done on trial at this time.
All right,
I've had patients fail, and it's upsetting. I've had them fail on all different modalities, and it's very upsetting. And I'm going to say, even though the reported salvage rates are 70% or 80%, that doesn't reflect the kind of challenging difficulty and how much more advanced the disease can be at recurrence.
No, I totally agree. Don't listen to the surgeons. Stick to your, no, because you're not going to be able to go back and radiate that. You know, we've learned by talking to our radiation oncologists over the years, and so, yeah, we never don't radiate the primary site or the stuff
Can you repeat that, what you just said?
Nobody taped that, right?
I have a question for you, Francisco. Okay, I'm gonna give you a hard case. Okay, so patient has an outside tonsillectomy. Margins were positive on this tonsillectomy, which, you know, was not done with oncologic technique. Patient now comes with quote-unquote positive margin. Are you going to take that patient for a re-resection with TORS, taking out, you know, proper oncologic technique, superior pharyngeal constrictor and all that stuff when there's no gross disease in the tonsillar bed? Or are you going to let that patient go ahead with a quote-unquote positive margin?
So
Let's say it's a less than 1 millimeter margin. Let's make it a little harder. So technically clear, but defined by some as positive. Or less than 2 millimeters, because some people say a tonsillectomy of less than 2 millimeters is positive.
So it depends what your goals are. So this is a tonsil cancer with no lymph node involvement or clinical?
One lymph. Okay, yeah, N0. N0. Let's go for it.
Yeah. So
Monotherapy candidate.
I would talk to this patient. You know, so that is not adequate treatment. That's a big biopsy. So even if you accidentally got positive margins, you could get fooled. You don't like if I biopsied a tumor in the mouth, got squamous cell carcinoma, and they told me my biopsy had negative margins, I wouldn't believe it. You know, so if it was a biopsy procedure, I mean, the oncologic operation is getting a deep margin, and to get a deep margin, you take the constrictor muscle. The constrictor muscle is only a couple millimeters thick. It's not like, you know, if you're going right on the constrictor muscle, the most margin you could have is a millimeter. I mean, if you had 2 millimeters, that means it was somewhere on the inside of the tonsil and there was tonsil around it. But what if it skipped a little in the tonsil or something? I mean, I would not, or let's say our dogma would be you can't treat tonsil cancer with a tonsillectomy. Now, does that mean it's impossible to cure a tonsil cancer with a tonsillectomy? No, maybe there's one that you could accidentally cure with a tonsillectomy. Doesn't mean it's impossible, but it's just not reliable. So you're not going to do that. So if that patient wants to be treated without radiation, they have an option for having surgery and neck dissection. And if the neck is N0, which presumably it seems to be based on imaging, but may turn out not to be, but if it seems to be and it really is, and you resect the constrictor muscle, probably your specimen will have no cancer in it, then that patient doesn't need any more treatment. So you could offer them that, but the other option would be to go for radiation. And I think, you know, it'd be a close call. I mean, I think radiation would be a great treatment for that patient also.
So a follow-up question at your center, how do you define a negative margin on an oncologic tonsillectomy? How many millimeters?
So the millimeters isn't that important to me on a tonsil specimen because the constrictor muscle is an anatomic barrier. So whereas in the tongue base, I'd like to have at least 4 or 5 millimeters. In the tonsil, if the constrictor muscle is minimally invaded on the tonsil side, but it doesn't go through the constrictor muscle, I consider that the fascia of the constrictor muscle on the outside served as a barrier, and I consider that a negative margin. Especially if the constrictor muscle is not invaded at all, I consider that a really good margin. Regardless, it's only going to be a couple millimeters, but that's okay.
Sure, and how does your pathologist report that? That's the key. Sometimes they'll say positive, right?
Our pathologists will interpret that as negative and,
Okay.
and as the constrictor
So maybe it's
muscle being
educating.
negative. Yeah, and they will give us a distance from the deep margin and so on, and then we can interpret it as we choose.
Great.